Today, we are going to talk about pupils, and this is the first of 3 lectures that we will discuss pupils. Pupils are actually my very favorite ocular structure. Everybody, I think, should have a favorite ocular structure. The reaction of the pupils can tell us a lot of things about clinical problems. It can help us localize a lesion to the visual pathway versus the motor pathway. Even further, it can help us differentiate retina versus optic nerve problems. The pupillary pathway has both an afferent and an efferent portion. So remember that afferent is sensory and efferent is motor. The afferent portion takes information from the eye back to the brain stem, and then the efferent portion takes information from the central nervous system through the cranial nerves and the sympathetic pathway to the iris sphincter and the iris dilator. So just with a very quick test, we can get a lot of information about both the afferent and the efferent visual pathway. So we're going to start by going over an overview of the afferent and the efferent pathway. And our afferent pathway does follow the visual fibers for a portion of the pathway. So we're going to draw out both of those pathways. So we'll start by drawing the anterior portion of the visual pathway. So our eyeballs, and then the optic nerve, the optic chiasm, and the optic tract back to the lateral geniculate nucleus. I'm also going to draw out the midbrain, because that's where our pupillary fibers are going to end up. So for our afferent pathway, it's going to start in the retina, and those fibers are going to go through the optic nerve. The nasal portion of those fibers are going to cross at the chiasm, and then the visual pathway goes all the way back to the lateral geniculate nucleus. But our pupillary fibers are actually going to take off about 2/3 of the way through the optic tract and go through what's called the brachium of the superior colliculus, and go to the pretectal nuclei. Now notice that the same thing occurs with our temporal fibers. Those fibers are going to come from the temporal retina. They are also going to go through the optic nerve. They go through the chiasm, and our visual fibers again go all the way back to the lateral geniculate nucleus. But the pupillary fibers are going to take off out of there. They never get to the lateral geniculate nucleus. They go through this brachium of the superior colliculus and end up in the pretectal nuclei. So that is the afferent pathway. We also have a central pathway, and that's the pathway between the pretectal nuclei and the Edinger-Westphal preganglionic cells. So these are Edinger-Westphal preganglionic cells. So what happens with the central pathway is that about half of our fibers start at the pretectal nuclei and go to the opposite Edinger-Westphal area. The other half stay on the same side and go to the ipsilateral Edinger-Westphal preganglionic cells. The same thing happens on the other side. So they synapse in the pretectal nuclei. About half of the fibers stay on the ipsilateral side, and then another half cross over and go to the Edinger-Westphal preganglionic cells on the opposite side from the pretectal nucleus. That's our central pathway. And I do want to point out also these cross in the posterior commissure. Now, one of the things to notice about this anatomical setup is we are only drawing just one half of the pupillary fibers. The same thing is happening on the right eye that's happening on the left eye. So if you think about how those fibers come back from both eyes, the Edinger-Westphal preganglionic cells get input from both eyes. And this is important because it allows you to get a pupillary reflex in both eyes, even when you shine a light into only one eye. Now, we've talked about the efferent pathway in previous lectures, but we will follow that through again. The efferent pathway starts at the Edinger-Westphal nucleus, and that's going to follow cranial nerve 3. So it's going to leave the midbrain and it's going to follow cranial nerve 3 up to the ciliary ganglia. And then it synapses, because these are parasympathetic fibers, it's going to synapse and then follow the short ciliary nerves up to the iris sphincter. Same thing happens on the other Edinger-Westphal preganglionic cells. They are going to synapse and then in the ciliary ganglia and then follow the short ciliary nerves up to the iris sphincter. So we've covered most of this written information. The afferent pathway follows the visual fibers. The fibers then leave the optic tract and travel with the brachium of the superior colliculus to the pretectal area of the midbrain. They synapse in the pretectal nucleus, and then about half the fibers travel to each of the Edinger-Westphal areas. Then the efferent pathway follows the parasympathetic component of cranial nerve 3. These fibers follow cranial nerve 3 to the inferior division once it's in the orbit. And then from the inferior division, it travels to the ciliary ganglion. And then through the short ciliary nerves to the iris sphincter. Now, as I mentioned, one of the aspects of the anatomical setup of the pupillary fibers is that it allows for both a direct and a consensual pupillary light reflex. So the direct pupillary light reflex is constriction when light is shined in the ipsilateral eye. It also allows for a consensual pupillary light reflex. And what the consensual light reflex is that the pupil constricts when light is shined in the contralateral eye. So when a bright light is directed into the eye, both pupils are going to constrict. When you look at the pupil with light directed towards it, then you're looking at the direct light response. When you look at the opposite pupil, the one without the light being shined in it, that's the consensual pupillary response. So we are going to draw out our anterior visual pathway again. Back to the lateral geniculate nucleus. And then we're also going to draw the midbrain with our pretectal nuclei and the Edinger-Westphal preganglionic cells. So let's now say that we shine a light into this right eye. The signal is going to travel through the optic nerve. It's going to travel through the chiasm, and then it's going to leave the optic tract and go to the pretectal nucleus. Then the signal is going to go to both Edinger-Westphal nuclei, and from there, that's going to follow the cranial nerve 3 back up to the sphincter on the same side. That's our direct response, our direct pupillary response. So we shine the light in the right eye and the right pupil constricted. But we also have fibers from the Edinger-Westphal preganglionic cells on the other side. Those are also going to follow cranial nerve 3 up to the sphincter on the other side and cause constriction. And that is our consensual pupillary response. So we shine the light in the right eye. The light came back to the optic nerve. It came back through the brachium of the superior colliculus. It went to both our Edinger-Westphal preganglionic cells, and from the contralateral Edinger-Westphal preganglionic cell followed cranial nerve 3 to the eye opposite of the light being shined. So whenever we shine a light in one eye, we're going to get constriction of both pupils. So you can see that in this video here. As we shine the light in one eye, you'll notice that both pupils are constricting. So we get a direct response and a consensual response. Now we are going to discuss what happens if we have disruption of the afferent pathway. A disruption of the afferent pathway is going to affect the direct response of the ipsilateral eye and the consensual response of the contralateral eye. So this is going to cause a relative afferent pupillary defect. Or an RAPD. A disruption of the afferent pathway will not cause anisocoria. So both pupils will be equal in size. When the normal pupil is stimulated, both pupils are going to constrict equally. When the abnormal pupil is stimulated, then both pupils will react less strongly compared to the normal eye. So we use the swinging flashlight test in order to determine if a person has a relative afferent pupillary defect. Here, the patient is going to fixate on a distance target, and the doctor is going to move the light from one side to the other several times. It's important to make sure that each pupil is illuminated with an equal amount of light. So you want to shine the light in each eye for about the same amount of time, 2 to 3 seconds per eye. And you also want to have the transilluminator an equal distance from each eye. If there is no damage to the visual pathway, then there will be little or no change in the pupil size as you go back and forth with the light between the two eyes. If there is damage to the afferent pathway, then one of the pupils is going to dilate more quickly when you're shining the light alternately between the two eyes. As you shine the light in the normal eye, both pupils are going to constrict. But when you shine the light into the abnormal eye, the signal is not going to make it back to the midbrain. So both pupils are going to dilate. And then you move the light back to the normal pupil, and both pupils are going to constrict again. This image is figure 1411 from the textbook, showing an example of what will happen with relative afferent pupillary testing. So the top image, A, is showing the situation where there is no damage to the afferent pathway. Here, we're shining the light into the right eye. Notice that both pupils constrict. Now we move the light over to the left eye and notice that both pupils stay constricted. This is what will happen if there is no relative afferent pupillary defect. Now let's look at situation C at the bottom. This person does have a relative afferent pupillary defect in the left eye. We start again by shining the light in the right eye. Notice that both pupils constrict. Now we quickly move the light over to the left eye and notice that both pupils dilate. So this is telling us that there's not as much light getting back to the brainstem when we shine the light in the left eye. This is a left relative afferent pupillary defect. Now, B is also a relative afferent pupillary defect, but not quite as severe as what's seen in C. So here again, we are shining a light in the right eye, and you can see that both pupils constrict a little bit. Now we shine a light in the left eye, and both pupils constrict more. Now we shine a light back in the right eye, and both pupils relatively dilate compared to when we had the light shined in the left eye. So this is a right relative afferent pupillary defect, a little bit less severe than what is seen in C. A relative afferent pupillary defect is relatively easy to see if the lesion is complete, meaning all of the fibers traveling through the optic nerve are damaged. However, more commonly, only a portion of the fibers will be damaged, and then you can grade the degree of the relative afferent pupillary defect. A grade 1 relative afferent pupillary defect means that when we shine the light from the good eye to the bad eye does constrict, but then it dilates faster than the normal pupil does. A grade 2 relative afferent pupillary defect means that when you shine the light from the good eye to the bad eye, there's no constriction of the pupil, and then there's redilation. With a grade 3 relative afferent pupillary defect, you go from the normal eye to the bad eye, and there's immediate dilation of the pupil. And then with a grade 4 relative afferent pupillary defect, there's no reaction even to direct light. So let's go ahead and look at some examples of relative afferent pupillary defects. This first patient has a grade 3 relative afferent pupillary defect in the left eye. So what you'll see when we shine a light from the right eye to the left eye, you'll see immediate dilation of the left pupil. When we shine the light from the left eye to the right, you will see constriction of the pupil. And that's because both pupils are dilating when we shine a light in the left eye, and both pupils are constricting when we shine a light in the right eye. So here you'll see both pupils are constricting, the left eye dilates. The right eye constricts, the left eye dilates. So this is a grade 3 relative afferent pupillary defect. This next patient has a little bit more subtle relative afferent pupillary defect. She'll have a grade 2 relative afferent pupillary defect in the left eye. What you'll see is that when we shine a light in the right eye, both pupils are going to constrict. When we shine a light in the left eye, there won't be any constriction, but then both pupils will redilate. The redilation occurs because there's not as much stimulation getting back to the brainstem from the left eye compared to the right. So both pupils dilate, Then we shine a light back into the right eye, and you'll see that both pupils constrict because they were previously dilated. So both pupils constrict here. And then as we shine back light into the left eye, you'll see that there is no constriction and then a redilation. And both pupils constrict when we shine light back into the right eye. So let's go over why anatomically this occurs. So again, we will go ahead and draw out our anterior visual pathway. As well as our brainstem with our pretectal nuclei and the Edinger-Westphal preganglionic area. When we shine light into the left eye, a signal is going to be sent down the optic nerve through the chiasm into the optic tract, and then through the brachium of the superior colliculus to the pretectal nuclei. From there, a signal is going to go to both Edinger-Westphal preganglionic cells, and then back up through cranial nerve 3 to the iris sphincter of both eyes. So we shine a light in the left eye and both pupils constrict. If we shine a light in the right eye, and I'm going to draw the temporal fibers here only so that they go to the same pretectal nucleus. So we'll have the fibers then go through the optic nerve, through the chiasm, through the brachium of the superior colliculus to the pretectal nucleus. From there, we're going to have a signal going to both Edinger-Westphal preganglionic areas, and then through cranial nerve 3 to the iris sphincter on both sides. However, if we have a lesion of the right optic nerve, then note that no signal is going to get back from the right eye to the pretectal nuclei. Therefore, neither Edinger-Westphal nuclei is going to be stimulated, and neither iris sphincter is going to be stimulated. So if we shine a light in that right eye, then neither pupil is going to constrict. We shine a light in the left eye, and everything in the red pathway works because it's not going through our lesion. So we shine a light in the left eye, and both pupils will constrict. But then we shine a light back into the right eye, and nothing through the green pathway is going to work. So neither pupil constricts, both pupils dilate. So shining a light towards the damaged eye will result in a poor direct response and a poor consensual response. So let's talk about some causes of a relative afferent pupillary defect. You can get a relative afferent pupillary defect from a retinal lesion, but because the fibers are more spread out, A lesion of the retina would need to be quite large in order to cause a relative afferent pupillary defect. On the other hand, a very small optic nerve lesion can cause a relative afferent pupillary defect. In fact, pupil testing is one of the best ways to differentiate between retinal and optic nerve disease. Remember that in optic neuritis, 2/3 of patients have normal looking optic discs. If the retina and the nerve look normal, but the patient has a relative afferent pupillary defect, they most likely have an optic neuropathy. A subtle retinal lesion will not cause a relative afferent pupillary defect. Undoubtedly, if a relative afferent pupillary defect is due to retinal disease, the retinal disease will be significant enough that you will see the lesion. A lesion of the chiasm may cause a relative afferent pupillary defect if the fibers from one eye are affected more than the other eye. A lesion of the optic tract causing a complete homonymous hemianopia will actually cause a relative afferent pupillary defect on the contralateral sides. If the hemianopia is incomplete, so you have a lot of loss on one eye and a small amount of loss on the other eye, you'll get a relative afferent pupillary defect in the eye with the worse visual field. The reason that you get a contralateral relative afferent pupillary defect with a complete optic tract lesion is because the visual field is larger on the temporal side. So if we draw out our visual pathway, the temporal visual field is going to be larger than the nasal visual fields, in part because our nose is blocking part of the nasal visual field. Therefore, if we have a right homonymous hemianopia, as shown here, the nasal visual field of the left eye will come back and hit temporal retinal fibers. Those fibers then will travel through the optic nerve, through the chiasm to the ipsilateral optic tract. The same right homonymous hemianopia is going to hit nasal retina on the right eye. And I'm going to draw two lines to show that there are more fibers damaged on the nasal retina than the temporal retina because the visual field is larger. So those fibers are going to come back through the optic nerve. They're going to cross over to the opposite optic tract. So if we have a lesion of the optic tract, there are more fibers in that optic tract from the contralateral eye. Therefore, you're going to get a relative afferent pupillary defect on the contralateral side. You can get a relative afferent pupillary defect from the fibers in the brachium of the superior colliculus. This is one of the few places that you can get a relative afferent pupillary defect with normal vision. Remember that these fibers have left our visual pathway. And so a lesion of the superior brachium will cause a relative afferent pupillary defect, but will not affect the acuity or the visual field. You won't get a relative afferent pupillary defect from a lesion in the optic radiations or in the occipital lobe. The pupillary fibers don't travel that far posteriorly. You also don't get a bilateral relative afferent pupillary defect. By definition, a relative afferent pupillary defect damages more fibers in one eye than the other. You can get afferent lesions of both optic nerves. But if you are doing the swinging flashlight test and you determine that one afferent pathway is worse relative to the other, then you have a relative afferent pupillary defect in the worse eye. You don't get an ipsilateral relative afferent pupillary defect from media opacities, and that includes cataracts. You might think that when the light can't get through a cloudy lens to stimulate the retina, you would experience a relative afferent pupillary defect. However, this does not occur even with very dense cataracts. You may actually get a subtle relative afferent pupillary defect in the contralateral eye. This is because the light is scattered by the cataract. When the light is scattered, it hits a larger area of the retina, causing the cataract eye to have an enhanced pupillary response. This is really important to remember because a person with a cataract may come in unable to see. If you do pupils and he has a relative afferent pupillary defect in the same eye as the worst cataract, you should be suspicious that something else is occurring. The vision loss is not due to the cataract alone. Well, that covers the pupillary reflex and the afferent pupillary pathway. In the next few sessions, we will cover what happens if there's damage to the central pupillary pathway and the efferent pupillary pathway, both the sympathetic and the parasympathetic system.